let's take a closer look at what we're going to do with regards to treatment in a primary care setting and general treatment strategies. So we need to work with the lupus care specialist. It could be an internist, a rheumatologist, a nephrologist, a hematologist, even a dermatologist, and develop if the organs are not involved, develop a treatment plan and monitor the disease, and usually touch base with the lupus care specialist on at least an annual basis. Most commonly, we use non-steroidal drugs. Approximately 80% of all lupus patients take non-steroidals at some time in the course of their disease. Of course, because of its GI, renal, and liver toxicity, one has to be very careful. We are using a lot of diclofenac gel, which is only 6% systemically absorbed. Recently, the Orthopedic Society recommended that diclofenac gel be the first-line treatment for osteoarthritis of the hands. It appears to be very safe. It helps serositis and headaches and joint pain, but unfortunately, it does not do anything for the underlying disease. And we're going to go through the next level, which would be antimalarials, followed by corticosteroids, immune suppressants, and ultimately targeted therapies. So the non-steroidals treat inflammation, pain, and fevers, and the mechanism of action of antimalarials is that it raises the pH of the cell so that acid cells become basic, and when you raise the pH of the cell, cytokines such as interleukin-1 and interleukin-6 cannot signal to promote more inflammation. The immune suppressants and biologicals, of course, target B cells and T cells, and corticosteroids, all inflammation. It's that we have to decide if the patient has organ-threatening disease or non-organ-threatening disease. In other words, heart, lung, kidney, liver, bone marrow, or brain is organ-threatening and is treated one way, and non-organ-threatening disease, which fatigue, aching joint pain, and rash, is treated totally differently. Lifestyle is very important. We can also use topical agents for lupus, which go from sunscreen to anti-inflammatory agents to diclofenac gel. We also need to treat the symptoms of patients that may not be inflammatory, such as depression or anxiety, and comorbid conditions that are more common, such as hyperlipidemia or accelerated atherosclerosis. Also, from the physical measures, we use sunscreens, SPF or sun protection factor between 15 and 50, block ultraviolet A light, and they are often very, very useful. Changes in the barometer can make lupus patients have worse symptoms. It does not matter if it's hot or cold or wet or dry, but if the barometer goes from hot to cold or wet to dry, lupus patients are more symptomatic. We use heat or moist heat rather than dry heat for chronic injuries, whereas we use cold for ice. Occupational therapy helps patients to use assistive devices and maybe prevent carpal tunnel syndrome while on the computer, get on and off a toilet seat, in and out of their bedroom, in and out of a car. And sometimes patients, let's say farmers or fishermen who are outside all the time, or construction workers, would do well with being trained for more of an indoor job. Diet, there is no special lupus diet, although we think that fish or fish oil is useful. Vitamin D is often low in lupus, and it might be helpful. And there is some evidence with work evolving and understanding our microbiome that there may be a lupus diet, but it is not yet determined what the best diet would be. The best way to treat fatigue without medication is to pace yourself. If you lay in bed all day, 20 hours a day, a young housewife, she's going to be only more tired. If she's Wonder Woman and works 20 hours a day, she will be wiped out for days at a time. So be active for a couple of hours, pace yourself, rest for 20 minutes, be busy for another couple of hours, take a lunch break. If you take 4 or 5 breaks during the day, most lupus patients with non-organ threatening disease can get as much done as any other woman with the disease. In addition to educating the patient, if you don't take a drug, it won't work. And non-adherence or non-compliance is a major issue. Patients need to have access to the specialist, even if they don't have a rheumatologist. Their primary care doctor usually can always call one on the phone or consult somebody. Cognitive behavioral therapy or biofeedback help Raynaud's, help the dysautonomia, and are anxiolytic. And we screen patients on a regular basis for the development of hypertension, hyperglycemia, hyperlipidemia, and obesity, especially in those who are on corticosteroids with at least annual screening. Hydroxychloroquine is not absorbed as well in patients who smoke. Raynaud's gets worse in patients who smoke. We do annual bone densitometry in people who've had the disease for a long time, or we get it at least on a regular basis. We screen patients for cardiopulmonary disease in those at risk. Anybody with lupus who develops a fever needs to see a physician. And we need to, in those who are at high risk of having a thromboembolic event, we need to either prophylax them with aspirin or some type of blood thinning regimen.